Welcome. Good afternoon. My name is Dr. Steve Plaxe. I'm a gynecologic oncologist and director of the Lucy Curci Cancer Center here at Eisenhower. I'm also a professor of reproductive medicine at UC San Diego. For the last 6 years or so, UCSD and Eisenhower have had collaboration and affiliation agreements largely focused on oncology, but in other areas as well. What we've tried to do as part of the affiliation is to really collaborate on clinical quality, clinical research, shared learning activities, and then collaborative management of patients. And we've done quite a number of interesting and valuable initiatives, brought world-class cancer care into the Valley. We have on-site clinics from professors at UCSD. We also have telemedicine options and opportunities. Our Eisenhower doctors and UCSD doctors collaborate through tumor boards and shared conferences, and it's really gone quite well over the last several years, and we're continuing to develop all aspects of the collaboration. Today we're going to talk about lung cancer, and I'd like to introduce our panelists. Right here to my left is Dr. Davood Vafai. He's a medical oncologist, and he sees a broad range of hematology and oncology patients. His interests focus on lung cancer and blood cancers, including lymphomas, leukemias, and multiple myeloma. He trained at USC and had a part in designing the chemotherapy regimen used for lung cancer, including carboplatin and Taxol. He presented that work at the American Society of Clinical Oncology meeting, and since then this treatment has become a standard of care in the U.S. and throughout the world. Next to Dr. Vafai is Dr. Delshad Ahmad, also board certified in hematology and medical oncology, and he is dedicated to providing personalized cancer care for his patients and for their families. He strives to provide patients with all options for their disease. Since every patient and every treatment is unique, Dr. Ahmad works to understand goals and provide the patients with all the information they need to accomplish their goals and to be partners with them in developing a treatment plan. And finally, at the end of the row here is Dr. Sandip Patel. He's also board certified in hematology and medical oncology. He's the director of the clinical trials office at UC San Diego and an expert in cancer immunotherapy, personalized medicine, and early phase clinical trials across all kinds of cancers. His focus is on developing personalized treatments that stimulate a patient's immune system to attack their specific cancer. He believes in offering these promising immunotherapies across all tumor types, and his research focuses on developing biomarkers for personalized therapy to better determine which combination of targeted agents works best for each individual. So we have an all-star panel this afternoon. A little bit of housekeeping first. As many of you know, November is Lung Cancer Awareness Month, and we're delighted you're joining us today for this special presentation entitled Current Treatment Options and Future Promise for the Treatment of Non-Small Cell Lung Cancer. Before we start, here are some housekeeping items. When you join the Zoom webinar, you'll automatically be muted and your video will be turned off. We will hold questions from the audience until the end of the discussion. You can type your questions via the Q&A tab, and we'll be sure to answer them for you. The discussion is being recorded, and it will be available on both the Eisenhower.org website and the Eisenhower Health YouTube channel within the next 2 weeks. If you need further assistance with cancer-related matters, please feel free to call us at 760-834-3798 or email Allison Sachs, asachs, S-A-C-H-S, at eisenhowerhealth.org. Now for the discussion. First up, Dr. Vafai. Could you talk with us a little bit about early detection and screening for lung cancer?
Sure. Well, first, thank Eisenhower for giving us this opportunity to share our knowledge with patients. It's a very nice thing to do to address the screening, the early stages and late stages, and all the new developments in lung cancer. Lung cancer is a very common disease. Unfortunately, is a deadly disease. But that said, there is a very good treatment if we detect it in a very early stage. These three conditions are the main foundation of and a screening program to be successful. essentially meaning that a screening can be successful when a disease is common, when a disease is unfortunately very deadly, and when the disease has a treatment that can change this whole picture, providing we detect this disease early enough. For that matter, we have to know, and this has been historically the thing with lung cancer, that most of the lung cancers, they present in a very late stages of disease. We call them stage 3 and 4, where we do not have that much of a very effective treatment for them, although the past 10 years has been an explosion of science, and we're advancing even in the late stages very fast, and we are finding and we are using very effective treatments, which Dr. Ahmad and Dr. Patel will discuss that with you. But the burden of proof has been that if we can detect this disease early, instead of finding this disease at a later stage, which now is about 50-60% of the times, if we can detect this disease in a very early stage. But having said all of that, then one of the very important things that comes with the early cancer detection is the smoking cessation programs that are fundamental, that people need really to focus and take that very seriously. We now have had a landmark study in lung cancer screening. The history of the lung cancer screening goes to many, many years ago, even 1960s and 70s, where we were using chest x-ray as a modality to detect this disease early, but unfortunately it did not work, and there are many reasons for that. Then about sometime around the early 1980s, a group in Cornell in New York started using CAT scan, a CT scan, to detect lung cancer early, and I began to become interested in that somewhere around early 90s, and we brought this program to Eisenhower, and it's been really a very effective modality. For now, I mean, the criteria that we have now, which again changed in March 2021, is that we essentially look and see how many years the person has smoked, which should be at bare minimum 20 years, and at bare minimum 1 pack per day. If that be the case, that person would be considered a high risk. By high risk, we mean that people who, if we do this screening, there's a high likelihood that we can detect a nodule, a spot, something in the lung, that we can either pursue that, follow that with serial CT scans, or even do surgery. If we do the surgery in a very early stage, primarily if the nodule or if that spot is less than 1 centimeter or 10 millimeter, then we have about almost close to about 90% success rate of 10 years survival, which is unheard. Never we had such results with lung cancer. So for that matter, with that very high efficacy in terms of both detection and impacting on the survival, a landmark study by National Lung Cancer Study Group started and was published in 2011 in one of our main journals that showed that if we pursue this, we can impact on the mortality of this disease and reduce the mortality 20%, and even have a non-lung cancer mortality reduction of about 6.7% by detecting coronary artery disease earlier, atherosclerosis, aortic aneurysm earlier, etc. So this screening really became a very powerful tool to not only detect this disease early, but also reduce the mortality and improve survival. Unfortunately, this has not been as much used because there's been some resistance to that, and partly because also the primary care physicians have been very busy discussing the pros and cons and provide shared decision making, which is a fundamental thing, and it's one of the requirements by Medicare that would allow people to undergo these CT scan screening, meaning that they need to know the pros and cons of that before they participate in it. We think that the 20% reduction in mortality is a very significant endpoint. Just for comparison, the mammography that is used for ladies to detect breast cancer has roughly about 5% reduction in mortality. So 20% reduction in mortality is enormous. More importantly, the landmark study of NLSD only did 3 years of screening. But if you extend that and do that up to age 80, which now is the criteria, we can increase that probability of survival further. So we would suggest and advise all patients to discuss this with their primary care physicians if they are high risk. For low risk patients, the jury is out whether or not the screening would work. I personally have some, bias toward that. But again, aside from that, scientifically, we do not have as much data on that as we have for the high-risk patients. But if somebody has smoked 20 years or more, 1 pack per day, we would encourage them to discuss this with their primary care physicians. We'll be more than happy to help if they have any questions. Also, we would strongly encourage them to participate in the smoking cessation programs.
So let me follow up with a question. So let's say somebody hasn't smoked for 20 years for a pack a day, but they're really worried. What do? Do they get screened?
Yes, I think they should be screened. But again, as I said before, the best thing is for them to discuss the pros and cons either with their family physicians or with the Eisenhower physicians.
And what's the role of secondhand smoking in lung cancer risk? So what about if their partner smoked a lot?
Correct. Again, the data is not complete. We are collecting information on secondhand exposures. It is very difficult to quantitate secondhand smoking. It is almost, I would say, impossible to really quantitate that. But again, the data is accumulating. I think we need to wait for more data.
Okay. And how does the process, you mentioned a mammography as an analogous process to screen for breast cancer. So for someone who's at normal risk for breast cancer, it's an annual mammogram. For somebody at high risk, it may be an annual mammogram and an annual MRI alternating. Right. What is it for lung cancer? Is it once a year? Is it once every 6 months? Is it one shot and you're done? How does that work?
We do one-shot screening, depending on the findings. As a general rule, we detect a positive finding when there is a density more than 6 millimeter in the lung. And if that be the case, we may, depending on the configuration of that spot and where it's located, etc., we may decide to do another CAT scan in 3 months. And if there is no further growth, again, depending, and these are all being discussed in multidisciplinary team situation, then we may decide to repeat this CAT scan in 1 year. We do not necessarily jump on doing invasive procedures, but we may need to do more screening.
Okay. And so if you repeat it in a year and it's stable, that's it? Or do you keep
No,
repeating
then we would put them on annual CAT scan screening up to age 80.
So eventually it turns into, for certain patients at a certain level of risk, it turns into an annual,
correct,
kind of an annual event like a mammogram.
Correct, just like mammogram.
Understood. Okay, great. That was very, very interesting. Dr. Ahmad, you're up next. So could you tell us a little bit about the treatment options for early stage lung cancer?
Well, I mean, definitely before talking about the treatment, I think we just some definitions, so if the listener can understand that. So definitely after what Dr. Vaphai has mentioned, if the patient presented with some symptoms, usually the diagnosis happens by biopsy, meaning, you take a sample from what you find on the imaging, and then then really the patient get diagnosed with lung cancer. And really the treatment options depending on what stage it is. Staging meaning how advanced is the cancer, or did it spread somewhere or no. Generally there is 4 stages, so it's the higher the number goes, the worse the prognosis. And there is multiple things involved in getting that detailed evaluation. So there is no really one straightforward treatment plan for one patient with a specific stage. It depends really how is the patient in general, how old is he, how is his lung in general, how is his health otherwise. And that involves really doing a PET scan, which is, or after it depends where did you start, generally with a CT scans and a PET scan. And also add to that sometimes MRI for the brain. That really on the imaging that shows how is it the cancer limited to one area, or did it go to other areas? And in addition to that, you most of the times, if it is not spread, then we need to get evaluation for the lymph nodes in the mediastinum, which is a cavity between both lungs where there is the lymph nodes, to see the extent of the disease. So after that, really, then you get to know what stage is the patient's cancer at. And in addition to that, there is different pathologies also. So there is the biggest category of lung cancer is the non-small cell lung cancer, which is almost 85%. Roughly, and then the small cell lung cancer is almost 15%. So those are also treated differently. So the main thing really is to find what type it is and to see the extent of the disease, and then make final plan, which involves multiple specialists really, including the pulmonologist, who is the lung doctors that do the bronchoscopy, which is, or sometimes the interventional radiologist. The bronchoscopy is really they're going through the throat to reach the lump or the mass inside the lung to get the biopsy, or even with that to check on the lymph nodes in the mediastinum, versus the CT guided, they go through the chest and get a sample from the nodule or the mass. That's one or two specialties that get involved. In addition to that, there is the radiation oncologist who treats cancer by giving radiation. Those are definitely, they have a very important role in treating lung cancer. And of course, the cardiothoracic surgeons in case. So generally that get discussed in a lung tumor board, which we have monthly, and all of subspecialties meet to make that decision clear. And really that get discussed with the patient to see. So there is no one really straightforward, one specific treatment for a person. It really has to have a detailed evaluation for all of the aspects of the disease and the extent, and then the decision is made after a discussion with the patient.
So there are patient-specific things to look at, and then there are disease-specific things to look at.
Yes.
So we put those all together in a kind of an amalgam and come up with a suitable treatment plan. One of the things you mentioned was a biopsy. So either fine needle aspirate by a interventional radiologist or bronchoscopy by a pulmonologist. Is it always necessary to have a biopsy to start treatment for lung cancer?
Yes. I mean, technically you should not, we don't define a patient to have cancer 100% without. Now, rarely when you cannot get a biopsy, you could make that based, but we don't scientifically really, you should not have the diagnosis or make a plan without a biopsy. Very rarely we end up really doing some treatment if we cannot get a biopsy based on if the patient has major comorbidities, but that's really not advised. So.
Okay. And if interventional radiology and pulmonology can't get to it, then how do you get the biopsy?
Really that's after the discussion with the patient to decide. So I don't make, without the biopsy, you don't know what type it is. You don't know, is it really cancer? Sometimes it could be just an infection. It could be just an inflammation. And, most of the cancer treatments have some toxicities or issues coming with it. So it depends really what the patient feel, the doctor impression and the patient feelings about the treatment plan, but that's definitely not advisable.
Does anyone ever need surgery to get a biopsy? thoracic surgery? Is that ever done?
That is done too, but unfortunately, most of these cases, they happen with the patients when they don't have good lung enough to do biopsies. So most of the times, it can be, yes, if you couldn't get a biopsy, you could go with surgery from the get-go without a biopsy. But most of these patients where we cannot get a biopsy, those are the ones that have been on oxygen, or they have a lot of heart issues, or they are already on oxygen. And that's where the importance, what Dr. Vaphai mentioned, is really having the screening, and if these patients where their cancer was caught earlier, or then there was a significant difference between managing them at later stage, or if they did not have lung cancer, they did not have major lung damage by smoking, then their prognosis would have been definitely a lot better. But I mean, at the end, yes, if you could not do a biopsy, you proceed with surgery. But with surgery, you're taking part of the lung out. Mm-hmm. So usually you have to have good reserve, and you have to do what we call it pulmonary function test. So what is left in your lung is going to be able to carry enough oxygen to provide your body. And unfortunately, that's not, a lot of the times that's not possible still.
So the way, how well the lungs work before treatment, whether it's surgical treatment or whatever, that has a lot of impact on the choice of therapy.
Yeah.
Can you talk a little bit about some of the things that are associated with lung cancer that might affect the pulmonary functions? What might make someone who has a lung cancer not such a great surgical candidate?
Yeah, so this is actually a common scenario where we see, that because the smoking not only causes lung cancer, it causes damage to the lung in general, and it causes what we call COPD. Most commonly that we see in these patients, a lot of them are depending on oxygen because they have damaged the lung from the smoking, and they are already depending on oxygen from outside, so or through the machine. So usually, if you have to do a test, which is really you puff into the machine and it measures how much volume you have in your lungs, and you have to reach a certain criteria. So by that, then the surgeon will be able to decide that really he can take a part of the lung or no. So a lot of those, when we cannot do that, then if it is early stage, meaning it is confined to one area, radiation only to that area is very reasonable option if you cannot do surgery, versus if it is spread, it's more of medication treatment. But if it's almost, radiation is almost effective almost to 90% in these patients where they cannot go for surgery. But of course, it has to meet certain criteria that it is small and limited to one area, didn't spread.
Okay, so there are common things. So the underlying cause of the lung cancer also can be something which adversely affects the ability to have surgery.
Yep.
There are common themes here, so okay.
Yeah. Most of those have heart issues also from smoking in addition, smoking not only causes lung cancer, there is a ton of other things that could come with it. And that's the most common cause for the cancer. So most of these people really are sick from other diseases also that can sometimes limit your treatment options.
Now you talked a little bit about staging and the importance of staging and significance of the lymph nodes. So we went over how the primary tumor nodule is evaluated. What are the methods for evaluating the lymph nodes?
So that's usually done by what we call it by bronchoscopy or EBUS. That's done by the lung doctor again, generally. I mean, there is surgical techniques also that's done by surgery. We call it mediastinoscopy, but generally it's more done by the lung doctors. And again, when they go through, it's the same thing if somebody went for endoscopy, they go through the throat and they reach out to really where is the cancer. So, and they also reach the cavity between both sides of, in the middle, we call it mediastinum, where there is the lymph nodes. And they take sample from multiple lymph nodes, and that really gives us the final impression how Are they involved or not, and how many are involved? And that's very significant in making decisions, really, what the treatment option will be.
How does lymph node involvement affect the treatment options? How do you factor? So let's say you've got a patient who has a lung nodule and no lymph nodes involved, and then another patient who has the same lung nodule but lots of lymph nodes involved. How does that work?
Yeah. So generally, the main thing that we always prefer is really to do surgery. But the surgery can get limited if there is lymph nodes involved on the other side where you have cancer. In general, this is not very specific, but generally if you have still lymph nodes on in your lung or one side of the mediastinum, that still could possibly be treated with surgery, of course, if they have enough reserve in the lung and all of that. But mostly if it went to the other side where there is a lung, let's say the lung cancer is on the right and the lymph nodes on the left side of the chest get involved, then that generally limits the surgery the surgery options. There is still, most commonly these patients will become stage 3, and most of those will get treated with chemo and radiation together. So generally, if it is just limited to one side, let's say you do chemo and surgery, and most commonly you do surgery, then you do chemo for a few months. And now we have approval even within the last month to get immunotherapy after those, after chemotherapy for these patients who did go for surgery. If you couldn't go for surgery because there's too many lymph node involvement, then you do chemo and radiation. And then after that, really, if your cancer is still under control, generally you do immunotherapy. And sometimes for the one that we mentioned that they went for surgery, there is certain mutation, like EGFR mutation. If you have that mutated on the cancer cells, then there's a pill type of targeted therapy that helps too.
Great. That's a perfect segue for Dr. Patel, who's going to talk with us a little bit about the future of lung cancer care.
Yeah, and so I think a lot of what we've heard already is the future of lung cancer, here and now and today. And I think the idea that we can find more patients early on in their lung cancer course so they can have curative intent surgery, curative intent radiotherapy, of which modern radiotherapy methods often, for patients who aren't good surgical candidates, can eradicate disease and cure patients. And then find patients even who have lymph node metastases or maybe spots in other regions of the lung and do appropriate molecular testing or immunologic assessment. We talked about EGFR earlier for targeted therapy with osimertinib, which is a pill, for 3 years. But also if you have immune cell expression of PD-L1, you can get immunotherapy for a year with atezolizumab after completing surgery and chemotherapy, or as mentioned, after radiation. And so the idea that we're trying to build off of what we have, which is chemotherapy, surgery, radiation, and add the novel therapeutics, the new types of therapy that are targeted therapy or immunotherapy, you really need an expert group of doctors, as we have here, to make that happen. And they need to be able to understand complex information, whether it be single gene testing, EGFR, multi-gene testing, next generation sequencing, PD-L1, immune status. All these factors are part of personalizing medicine just as much as looking at pulmonary function testing, looking at scans, and trying to individualize treatment plans. And so having an expert team like we have here that can participate in tumor boards and can understand a patient holistically, I think is just so key in taking care of these patients.
Okay, so that covered a lot.
Yeah.
So you talked about immunotherapies, and then you talked about EGFR and targeting certain mutations. Could you maybe go through, for those of us who may not be that familiar with the basics of that, maybe start with targeted therapy, personalized therapy. So what does it mean if you have an EGFR mutation? And then subsequent to that, what's immunotherapy? How does it work? What does it do? Just some basics.
Absolutely, great questions. And so I think everyone's cancer is unique. and some patients can develop lung cancer who've never smoked at all. In fact, if you have lungs, you can get lung cancer. Similarly, you don't have to take hormones to have breast cancer or really have other high-risk factors to get other types of cancer. And so there's a group of patients who often haven't smoked but could have smoked, who have a mutation in a gene called EGFR. And if you have this mutation, they're actually pill-based therapies. There may be your most effective therapy, more so than chemotherapy. And these can be given if you have widespread disease, stage 4, and now even in earlier stage disease, as we discussed earlier, all the way from a post-operative stage 1B, meaning a small tumor, lymph nodes aren't involved, to stage 3A, meaning you have a certain region lymph nodes involved that are kind of lower level, even with cancer in the post-resection setting. And so the only way to know you have EGFR, for example, or a variety of other mutations, is to have the appropriate molecular testing done. This can be done in tissue. It can now be done in 2 tubes of blood. But it's not just as simple as getting the test. It's interpreting the results of the test, which can often be complex. And oftentimes there can be red herrings where you have EGFR mutations and high PD-L1, and the PD-L1 is trying to trick you into doing immunotherapy, where your best treatment is actually that targeted therapy. And so having the expertise of physicians who understand the test, who have access to tumor boards, to divine what makes the most sense for a given patient, I think is key. And so fundamentally the way a targeted therapy works, it's not chemotherapy, though they can sometimes be IV-based therapies. They're often pills, and they're pills you take that basically block whatever's fueling the cancer's growth. And the way you detect what's fueling the cancer's growth are through these next-generation sequencing tests, PD-L1 tests for immunotherapy, which help you understand what makes that patient's cancer tick, and how you can throw kind of an appropriately sized monkey wrench at the cancer without having all the side effects elsewhere optimally. With immunotherapy, the currently FDA-approved immunotherapies, which are IV infusions of drugs that stimulate your own body's immune system to fight the cancer, the best way to think about them, in my opinion, is that they're really pro-drugs. The actual drug is the patient's own immune system. And in fact, you can sometimes get toxicities that are friendly fire of that immune system, starting to recognize the skin as foreign, as the thyroid is foreign, and you may need steroids to intervene on that. And so this goes to the point that having an expert group of doctors who can help take care of all these toxicities that can develop during a patient's journey is so key, because there are many patients who receive immunotherapy that can be cured of their immunotherapy, meaning they get 2 years of immunotherapy, and even 3, 4, 5 years after their last dose, they're still in remission because the actual drug is their own immune system that was stimulated by those therapies that they got over a multi-year period. But I think the key aspect, and you heard this multiple times, is personalization of therapy, right? If you have too much lung damage, that surgery is not your best option, well, let's do radiation instead, right? If you have an EGFR mutation, maybe you're doing this targeted therapy, versus if you have an immunotherapy signature, maybe you're doing this immunotherapy signature. And so the ability to understand those results, get that appropriate testing, and get on the right therapy not only is important in the standard of care setting, but now increasingly for clinical trials and the next generation therapy that's out there. Many of us, probably all of us, have had our COVID-19 vaccines, right? Most of us, I think all of us, got them before they were formally FDA approved. Similarly, in cancer, we're starting to see some of the latest and greatest therapies are being developed and can be accessed in clinical trials before they're available, and having colleagues who have access to those therapies is really key to make sure patients understand all their options in terms of their treatment.
So when should all that testing be done? Is it done at the time of diagnosis? When does it all get done? And the second follow-up to that is, does the tumor change over time?
Yeah, great question. The answer to the first one, I say kind of tongue-in-cheek, is yesterday, right? Okay. Meaning you hope a patient has a new diagnosis of metastatic cancer. You can order the testing and have those results. With a liquid biopsy, you typically get the answers back in about a week. With the tissue biopsy, it can typically take 2 to 3 weeks to get the results. And it's so key. It's like driving without a roadmap, right? And so you want the results of that molecular testing, immunologic testing, PD-L1. And some of these can change over time. So let me tell you a patient story just from my own clinic. I had a patient with an EGFR mutation. They're on a drug called osimertinib, which is a targeted therapy, and they started to have growth after 3 years. And we did a liquid biopsy, and we found the patient acquired a RET fusion as their resistance. And normally we'd aim for a clinical trial, but this patient had baseline issues with kidney and liver function. They were never going to be a trial candidate, unfortunately. And so the generosity of working with the companies, the insurance unfortunately denied this. We gave a RET inhibitor on top of their osimertinib targeted therapy, and the patient had over 50% shrinkage of their cancer. And so that goes to the point that sometimes the type of resistance the patient develops, it turns out there's something in the tool shed that you can use already that's approved for another type of cancer, and you have to look first, and then you have to match that patient to that therapy. And ideally you do this in clinical trials, but for some patients a clinical trial is not going to be an option due to comorbidities, and you're able to use a drug that's approved in another setting to help them and do that. And so it can change. There's, in the same way, antibiotics, right? You give an antibiotic for a while, they get resistant. You give a different antibiotic that overcomes that resistance. But you have to do the proper testing to understand that sometimes that's a liquid biopsy, sometimes that's a tissue biopsy. And depending on what you need, you may have to do a repeat biopsy to understand what's going on at that given point in time, as opposed to looking back in time, which isn't going to be as informative.
Well, that's pretty complicated. So EGFR, I guess, is an important thing in lung cancer. What does that stand for?
Epidermal growth factor receptor. And so EGFR is part of a superfamily of receptors that cause cell growth. And so EGFR in the lab is formerly known as HER1. If you treat breast cancer or gastric cancer, HER2 is the partner for EGFR, actually. And then you have HER3, you have HER4, and they actually will sometimes dance together to cause cancer to grow. And so you have drugs to block them. For lung cancer, you tend to block EGFR more common, or colon cancer. For breast cancer and gastric cancer, we're blocking HER2 more common. Turns out blocking HER3 may have implications in certain types of cancer. And so we're finding out more and more, though, that there are unique cancers that have upregulation in these proteins that don't neatly file into just breast cancer or just lung cancer. And so having that panel more and more for patients with just metastatic cancer is key, because we're starting to see FDA approvals for drugs regardless of the cancer type of origin. If you have a tumor mutational burden greater than 10, if you have an NTRK fusion, regardless of where the tumor came from, you can have access to these potential therapies. Microsatellite unstable tumors, right, which are more common in gynecologic malignancies, for example, endometrial cancer. You can find them in colon cancer, biliary cancer. You can use immunotherapy for patients regardless of where it came from, or even if you cannot find out where they came from, as long as you do the test. And the test can be done in tissue, but it can also be done in blood. And these therapies are transformative. If you make the diagnosis in the right patient, you can have patients here. For years, we had a patient I saw now over a year ago who had a gynecologic tumor, could never identify it. Was it endometrial? Was it ovarian? You couldn't quite tell. And she was, listen, I'm thinking about hospice, but my sister said I should come and see you. And so she saw us in clinic. She had no tissue left over. We did a liquid biopsy and found out she was MSI high. And so we put her on immunotherapy, and now over a year later, she's in a complete remission, right? She's out of her wheelchair. She's doing all the things she likes to do. And it goes back to the point that sometimes even when you can't name that tune exactly, if you do the right testing, you can get the right therapy for that patient. It can be life-changing. And so now we can do it in tissue, we can do it in blood, but the idea that we at least do it once for that patient to understand what makes that cancer tick, and if we can find that, home run, to help that patient, I think we're starting to see more and more of this, because our diagnostics are getting better as our therapies are getting better.
So that's an enormous paradigm shift. So 20, 25 years ago, even 15 years ago, the way we used to treat cancers was based on where they started or what they looked like under the microscope. What I think you're saying here is that doesn't much matter anymore. When you use these new targeted tests, immunotherapies and so forth, what determines treatment is what the profile, the genetic profile, the immunotherapy profile looks like, and it's agnostic as to where the tumor started or what it looks like under the microscope. Is that right?
Increasingly so. I think it's important to have the information where the cancer came from, because oftentimes we'll combine, especially immunotherapies, with traditional chemotherapies, and they actually potentially work synergistically together in some scenarios. And so it is important, well, I think it came from the stomach, or I think it came from the lung, because it affects more the chemotherapy therapeutic backbone. But you're absolutely right, from an immunologic perspective, the immune system doesn't care if the cancer came from the stomach, the lining of the stomach versus the lining of the endometrium versus the head and neck. And in fact, the PD-L1 scoring, the only difference is you may get one PD-L1 score if you're a lung biopsy, but a different PD-L1 score if it's like a stomach biopsy, right, for that type of cancer. But it's whether you have that PD-L1 there or not that tends to matter. And you're absolutely right, from a mutational standpoint, it's about the genomics, right? And whether you have a HER2 amplification in the breast or the stomach or a mutation from the lung, you may get the exact same therapy, right? Because they're so potent once you make that match. And so I think it's very important to do your best to try to understand where the cancer came from and do the histologic diagnosis, what the pathologists help us with. I think that's absolutely key. But I always say there are 3 diagnoses we have to make in the clinic for our patients. The radiographic diagnosis, where the cancer is, the histologic diagnosis, what the pathologists say, well, this looks like colon cancer, this looks like lung cancer, that's where it started from, more small cell, non-small cell. And then the third is the molecular diagnosis. Right, and that's really, I think, where we move the needle, and I think it's what separates elite centers, such as what we have here, from others, is the ability to A, do the proper testing, but B, understand that testing in order to deliver the latest in therapies for our patients.
Yeah, that's fascinating. And I'm going to let you off the hook in a minute, but we do quite a bit of the specialized genetic testing here and immunotherapy testing here. It seems like many of our patients get that. And one of the things we share, and we talked a little about shared learning earlier, is molecular tumor board, which is something that's run through UCSD, and which we have remote participation. We present lots and lots of Eisenhower patients at tumor board. Can you tell us a little bit about that? What that really is? It's kind of an odd duck in terms of tumor boards.
Yeah, absolutely, and it's a great question. And so myself, Dr. Cotto, we co-lead a molecular tumor board, and one of the interesting things about the pandemic is it got us way more comfortable with virtual conferences, and it kind of tore down the need to drive into a specific conference room to get your answers. And we've had historically great participation, but it only increased as everyone, and the tumor board basically became entirely virtual. And so what this tumor board does is we look at patients, regardless of their tumor type, regardless of if they're treated in La Jolla, out here in the desert, anywhere in between, really, and we provide advice based on their molecular phenotype. And this really, I think, is the way tumor boards really need to go, because you go to a tumor board for a complex case that isn't a chip shot, right? And so that often involves rare molecular aberrations that may not completely make sense in a vacuum. And so we have genetic counselors involved in our tumor board who can help talk, is there any germline testing, anything that may have implications for family members, which I think is a question our patients ask and we want to be informative of. Are there clinical trials? If there's not a standard of care therapy, are there clinical trials for these patients? And then, what is the best test for my patient, right? And did I do it on the right sample? Is it something I should consider a liquid biopsy, tissue biopsy? What are all my options? So the tumor board is as much fact finding as it is fact generating, and it helps us understand, is there a given targeted therapy that can help a patient that it may not exactly be for their exact type of cancer, but there may be data out there that helps us inform. Because as we think about it, cancer doesn't read the textbooks the way we do, right? And so sometimes we have to be able to go off-road in order to best help our patients in a rational way as the cancer is going off-road. And so that's what molecular tumor boards really help us with, helping identify trials, and sometimes saying, hey, we may need to do a different biopsy or a liquid biopsy, because you may get in these scenarios where you may have to add something to what you're doing, like I mentioned earlier.
Fascinating. Okay, so now we've got some time for audience questions. Where are the audience questions?
We don't have any yet. Maybe
we don't have any. Okay.
I do have one from the audience here. Should I be worried about radiation from CT scans?
That sounds like a Dr. Vaphai question.
Yes. For all practical purposes, no. There has been some reports, at least to my assessment, that has been a wrong report comparing the exposure of radiation induced by these CAT scan machines, which now we have second, third, fourth generation of them, and they emit much lesser dose of radiation compared to what we had 20, 30 years ago. Aside from that, one of the major articles that came out against the radiation and bringing and raising the concern about radiation exposure was from a study that compared the total dose of radiation emitted and exposed by the CAT scan machine to the radiation exposure of atomic bomb in Hiroshima, which is a total wrong comparison. The radiation exposed by Hiroshima bomb was totally different compared to the CAT scan machine exposure. So you can't really compare apple and oranges. There was very different. For that matter, and there has been a lot of studies from our previous group that I've been associated with as ILCAP, that we have measured these radiation exposures, and for all practical purposes, there's not that much of a significant increase in risk of getting cancer by radiation.
Okay.
Can you read the second one from Plaxe?
No, it's kind of cut off. Let's see. Okay, so for the targeted therapy using osimertinib, is there a new clinical trial being done for the next generation drug? Anybody who wants to take that one, take it.
Yeah, I'm happy.
I just want to add something toward to these, and that's the question that I get from a lot of patients in the office, is that going back to the basics, lung cancer carcinogenesis and lung cancer formation, essentially, if we want to simplify it to some extent, is either via a non-tobacco related pathway, which EGFR is one of the major determinant of that, meaning that a lot of non-smokers, they develop lung cancer via that EGFR pathway, whereas the smokers, the people who use tobacco, for all practical purposes, the genetic pathway of that carcinogenesis and cancer formations was either KRAS and P53, two different genetic pathway. About 20 years ago, the data came initially from Japan, that a lot of non-smokers, the Japanese women were not non-smokers, they were developing lung cancer, and people started studying them, and we find these pathway of EGFR that is now we have a lot of treatment for that. So the targeted treatment started in non-smokers, and targeted treatment for now still benefit a lot of non-smokers, although we have a lot of, as Dr. Patel eloquently described, we have a lot of treatments for smokers, even in the context of targeted treatment. But a lot of these treatments were essentially help the non-smokers, including the osimertinib. So there's a lot of trials now addressing this, which I would allow Dr. Patel to elaborate on that. But we had the targeted treatment for the non-smokers. Now we have the immunotherapy for smokers. So this is what people get a little confused about. What is immunotherapy, what is targeted treatment, etc. I think that would be a thing for them to know.
Okay.
Yeah. And it's even more complicated than that, right? Because KRAS G12C in lung cancer has a targeted therapy now approved called sotorasib. It's a pill. But that mutation is almost exclusively found in people who've had cigarette exposure. So it goes to the point that a social history is nice, but you need that molecular information.
What kind of exposure?
Smoking.
Smoking.
Yeah.
Okay.
And so regardless of your smoking exposure, because there are patients who are 40-pack year smokers, they could have an EGFR mutation or an ALK rearrangement. And so the idea that just because someone has a spot on the lung doesn't necessarily mean it's lung cancer. It could be a different type of cancer. It may not be cancer at all. It could be a fungal infection. You have to make the diagnosis. And so the point about next generation drugs, absolutely. In fact, there are clinical trials looking at combinations of osimertinib. I alluded to one off-label kind of combination, but there's actually a trial if you qualified for that. There are antibody-drug conjugates, targeted antibodies that deliver chemotherapy just into the cancer cells that are being developed as well. And so, the future is bright. It's really about getting the adequate profiling to understand which of those paths make the most sense, getting that molecular map to tell you both in terms of standard therapies as well as research therapies what make the most sense. And then to just echo the point about the CT scans, the amount of radiation is quite low, and so as long as you're not pregnant basically or a young child, the risk of CT scans is low to that. All the people who went up to space, right, with SpaceX got way more radiation than you would get in a lifetime of CAT scans, right, when they went up there. Or if you went on a transcontinental or international flight now, that's the equivalent of several CAT scans with modern techniques. And so I have really no qualms, and it's something I explain to patients because it gets us such valuable information, right? We're not doing it willy-nilly. We're trying to understand, is there cancer there, right? And we're not trying to cause the very problem we're trying to treat in that scenario, outside of those rare scenarios of pregnancy, maybe a rare family history of DNA damage. For 99% of patients who are adults, it's really not an issue.
Great, thank you. So we've got two questions which kind of overlap and relate to how does a patient get presented at tumor board?
Usually it's the physician really just, reviewing his case and seeing the necessity to be discussed or between the panel, but that doesn't happen to every patient, usually more specific or complicated cases. But I'm sure if somebody is concerned about that and they want their case to be presented, I'm sure if they discuss that with their physician, they will discuss it with everybody. Sometimes we discuss outside the tumor board, so it doesn't have to be really tumor board also. So when it's straightforward case.
Yep. So I guess the short answer is you got to talk to your doctor.
Yeah.
And if he or she has access, they can make it happen. Okay, and then the next question is, therapy advances in lung cancer appear to be much more promising based on today's presentation. Would you say that lung cancer therapy is not as dismal compared to 5 years ago? So let's just kind of go around the room, see what everybody thinks.
Absolutely, yes.
Yeah, for sure. And especially now things are, what Dr. Patel mentioned, more in the late stage, coming to be studied in the earlier stages, and I think that's going to make a very, very big difference. We already seen a very big difference in advanced stage, and we're going to see it more in earlier stages too.
Yeah, I couldn't agree more. I think, and the proof's in the pudding. If you look at cancer-specific mortality in the United States for the past 2 years, these are the best 2 years we've had. The cancer curve is actually bent favorably. More people are living, surviving, being cured of their cancer in the past 2 years sequentially. Never happened before in the history of the US. And it's driven, if you look at the data, by improvements in lung cancer because it's the most common type of cancer that we see. And that data doesn't even fully reflect immunotherapy. That just reflects targeted therapy. And so probably about 1 in 4, 1 in 3 lung cancer patients benefit from immunotherapy. And so I think the best is yet to come. And we by no means won, the war on cancer by any means. But the idea that we're, getting some big wins to help our patients across multiple tumor types. I know this is lung cancer month, so we're focusing particularly there. But across multiple cancers, to the point that overall cancer mortality is improving for this country, I think really is a testament to our ability to detect these cancers earlier and cure patients once and for all with appropriate use of low-dose CT, but B, the appropriate use of targeted therapies and now immunotherapies to really help patients maximize their quality and quantity of life.
Okay, well that's great. We talked just a little bit earlier about clinical trials. What's the process to get on a clinical trial? Anybody?
And so typically it's a conversation just like tumor board to have with your doctor. And I always ask patients to, there are two questions you want to ask. One is there anything you'd be doing, right? The shoe is on the other foot for yourself, right? Is there another test? Is there something else to be doing? And two is, are there any clinical trial options available for me? And I think when you think about clinical trials, after you ask your doctor, they'll usually reach out to their research coordinators who will screen the patient, look at all the labs, the kidney function, liver function, the history, the type of cancer, the scans. And they'll say, oh yeah, trial A, B, or C may be an option. Then your physician will take those and review those with you. And I think that's a key part of shared decision making is finding your best treatment. Well, many times your best treatment may be in the context of a clinical trial, something new, right, that's about to be developed. And I think it's one of the two key questions I always ask my patients when they're kind of getting their second opinions. I always coach them, ask, is there anything else you'd be doing if it were me, right, if the shoe were on the other foot? And then also, are there any clinical trial options? And you'll often find that the clinical trials are designed to give you better than the standard of care. Meaning, if there are two arms of the study, even if you're getting the non-experimental drug, that non-experimental drug is the best therapy available for you. And we found, and if you look at a lot of the data, patients do better on clinical trials, even if they're getting the same standard of care therapy, than if it was just prescribed for them, right? And so there are multiple reasons for that, but the idea that it's at least worth investigating and having a discussion around, I think, is key.
Now, we've got a number of clinical research studies open here at Eisenhower. I know Dr. Ahmad and Dr. Vaphai both have been the principal investigators for these studies. And maybe just briefly, we've got 2 minutes left. Heather's got the sign. Maybe Dr. Ahmad and then Dr. Vaphai, just tell us briefly about some of the clinical trials we've got open here for lung cancer.
Yeah, there's definitely more into specific, more targeted therapies as of adjuvant therapy now and immunotherapy. And I think I have a couple that involves more of targeted therapy, and I think Dr. Vaphai had immunotherapy.
Yeah, we have the lung map study that I guess and still one arm that is still open, and it started as a cooperative group that put patients on targeted treatments versus immunotherapy. In the early stages, and is still one of the arms are still open, and we're trying to enroll on that.
Okay, so again, access to clinical research study is through your doctor, and we've got a number of targeted therapies looking at the newest advances in cancer treatment here, and several in lung cancer. So I think we're almost at time. So thank you all for attending. We're going to wrap it up now. Thanks to our panelists, and next time we'll be talking about something else.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.